We're ready.
All right, wonderful. Well, good evening, everyone. My name is Ashkan Lashkari, MOASC president. I'm really honored to be presenting this webinar with our moderator, Dr. Nataliya Mar, and our speakers, Dr. Stephen Seyedin and Dr. Przemyslaw Twardowski. Today's webinar is going to focus on the discussion on the management of prostate cancer in the advanced setting. And we have a number of important topics to review, and I'm going to transition the baton to Dr. Nataliya Mar, who's going to oversee this session as our moderator, and we're all excited to hear about updates in the management of advanced prostate cancer. Dr. Mar, thank you.
Thank you, Dr. Lashkari. Hi, all. My name is Nataliya Mar. We are having our third webinar today on a topic in genitourinary cancers, and it happens to be Prostate Cancer Day. So we have two wonderful speakers who will kind of help me discuss two topics that are hot topics in prostate cancer, a little bit controversial, something that we deal with in clinic every day. And I hear a lot of questions about these topics in clinic. So I thought it would be really nice to have a discussion around these topics. So just briefly about myself, I am an associate professor at University of California, Irvine. I am a medical oncologist and I treat genitourinary cancers. And I'm going to have both of our wonderful speakers introduce themselves. So maybe Dr. Seyedin can start.
Absolutely. Thanks, first of all, for MOASC and Dr. Mar and Dr. Lashkari for the invitation. This is my second time doing this, so glad that at least my first time went well enough to get invited back. I'm a radiation oncologist. I just started at UCSF about a couple of months ago, who focuses on the treatment of genitourinary cancer. And I look forward to speaking about, the role of radiation and the couple of our cases we have.
And if that's my turn, Dr. Mar, then I'll introduce myself. So I'm Przemyslaw Twardowski. I'm a medical oncologist specializing in GU, medical oncology, of course, prostate cancer being kind of dominant disease in that particular area. And I'm currently at St. John's Cancer Center in Santa Monica. Thank you for inviting me. Pleasure to be here.
Perfect. So for the audience, I would really love for this to be interactive. This is not a lecture. I want questions. I want comments, points. If something is unclear, please ask. Or if you have an interesting kind of pearl to share or a patient case to share, please ask. So I want this to be kind of, again, really an interactive discussion. So having said that, we are going to proceed. Just one second. There we go. So we'll frame this webinar around two patient cases just to make this kind of real life. And we'll start with case number one. So this is a case of a 64-year-old man who presented to his internal medicine provider with worsening mid-back pain for 7 months. Eventually, he ended up having an MRI of his thoracic spine that showed an abnormal infiltrative bone marrow signal in T3 with a posterior epidural soft tissue component causing canal narrowing and spinal cord compression and impingement. He then went on to have body CT scans that showed the T3 lesions and no other findings. He then had 2 additional MRIs of his C and L spine that showed additional lesions at C3 and L2. His PSA was 115.4, and he subsequently underwent resection of his T3 tumor and T1 through T5 decompression and fusion. Pathology from that surgery showed metastatic adenocarcinoma consistent with prostate origin. So this is actually a real patient that myself and Dr. Seyedin treated. But maybe we'll start with Dr. Seyedin since it's his patient. So how would you classify this patient's prostate cancer?
Yeah, sure. So, we have what seems to be lesions at C3, L2, T3, and then, and so those, I see 3 spots, right? So yeah, so this would be kind of what I would describe as that kind of oligometastatic space, right? With someone who has less than 5 sites of disease. And then obviously it's never been treated, so I would say castrate sensitive.
Okay, I agree. And then Dr. Twardowski, any other comments on this?
Yeah, so I agree. I think, one interesting aspect here that, we're not provided with Gleason score, right, which is usually not given, I think, if you obtain the tissue from metastatic site, but I assume, it's probably kind of high-grade tumor. I think that the fact that this is the de novo presentation is important in terms of metastatic presentation that typically is associated with worse prognosis than if you have metastatic disease following, prior localized disease that was treated with curative intent. So that's kind of unfavorable aspect of this case. But interestingly, by kind of standard definition that we use in terms of dividing patients into high or low volume disease, he would, I guess, make it into low volume without visceral disease or long bone involvement. So yeah, it's kind of the mixed picture here. There's a lot of bad things about it, but at the same time, it's considered low volume disease.
Yeah, so this is a really kind of wonderful point. So we have 2 definitions here that I listed. So generally speaking, if we have a patient who comes in with metastatic prostate cancer, whether de novo or recurred after localized therapy, we try to put him in one of 2 buckets, either low volume or high volume. And the thinking here is that these are somewhat different disease biologies, with the presumption that low volume patients tend to behave a little bit better clinically, have kind of less aggressive features, and high volume patients are the opposite. So the 2 definitions that we have, one came from the Charted trial, which basically classifies high volume disease as 4 or more bony lesions with more than one or more lesion beyond the vertebra or pelvis, or patients who have visceral metastasis. The second definition we have came from the Latitude trial, which is somewhat similar, but here they basically say that 3 or more bony lesions or visceral metastasis are considered high volume disease. But as Dr. Twardowski pointed out, these are not perfect. And sometimes you have a patient with kind of really aggressive features, such as, let's say, this guy with young age at presentation, de novo metastatic disease, and spinal cord compression as a presentation, kind of point more towards a more aggressively behaving cancer, but yet is classified as kind of oligometastatic or low volume disease. Any comments on this from our panel or audience?
Yeah, I would just again echo what you just said. These definitions, I think, are very useful, and they are incorporated in clinical trials quite extensively to stratify patients. But when you look at this definition, you theoretically could have 100 bone lesions in the spine and be considered so-called low volume disease, which intuitively doesn't quite make sense. But that's those are some of the limitations of this classification.
Agree. Absolutely agree. And I also again want to point out that you're totally right, and that so at least in our pathology department, Gleason scores are only reported on primary prostate biopsies.
Right.
Okay, so then we ask ourselves, how do we work this up? Do we need any additional testing, such as imaging or genomic testing at this point? So I kind of wanted to hear from our panel to see what would be your regular type workup for this patient.
Well, I think it's hard to avoid, I guess, doing PSMA PET. And the question is, how to really interpret that, of course, because there's, I think, significant likelihood that you'll find, more disease. However, that, classification we were talking about just up to this point is really based on the traditional imaging. So, but, I think still I find it valuable to kind of have a more detailed understanding of extent of disease with the best of imaging that we have. So now, would that change dramatically management? Probably not, although perhaps if you detect visceral metastasis in the liver, it may have some impact on what you do. I think prostate MRI may be of lesser value in the metastatic setting. And the germline and somatic genomic testing, certainly germline would be pretty strong consensus to offer that to the patient, or any high risk or metastatic prostate cancer. I think NCCN guidelines recommend germline testing. Somatic, I think it's arguable at what point you want to do it. It may not have, again, impact initially on initial first-line treatment, but I would probably do it and have that information kind of stored in the information bank, if you will, to have that knowledge in case of future disease progression and considerations, various considerations for second and beyond line therapy.
Yeah, so I agree. So specifically with regards to genomic testing, I tend to do it earlier. So anyone with a metastatic cancer in my practice gets both germline and somatic. The reason is maybe a little bit more practical than anything, simply because biopsy tissue gets old. And by the time they develop castrate-resistant disease, most of the time you have a few years that pass, and sometimes tissue just ages, and it's harder to extract kind of viable DNA from that. So I tend to do it earlier, particularly because a little bit down the road we have targeted, therapies that we can use for our prostate cancer patients. So I tend to do it early. And then I actually wanted to ask Dr. Seyedin about prostate MRI in this space, in this type of patient. What do you think?
Yeah, it's interesting. I think it just depends, because and we'll discuss kind of some of the trials that looked at, primary prostate radiation, right? They really just only treated just the prostate. So you could probably justify not doing it. My practice, I like him. And I said, just because if there's seminal vesicle involvement, I'm going to treat the entire seminal vesicle. And then, if it impacts your radiation design, granted, the dose in this kind of setting is a little bit lower, so maybe a little less meaningful. But in the future, there might be a role of kind of almost boosting where the bulk of the disease is, depending on the patient's presentation. So I like them. I think they give me a little more confidence, yes, especially if there's like rectal invasion, definitely.
Yeah, so I think the reason I threw that in there just to get your opinion on this, but I don't routinely get them, but I think in selected cases they might be useful if you want to kind of define the anatomic detail of the prostate a little bit, if you were gonna, let's say, give radiation or someone has symptoms in that location, it might be useful to have, but I don't do it in every single patient. The PSMA PET, I think now has entered the prostate cancer space, and I agree it's kind of hard not to get it at this point, although probably won't change much in terms of management, but at least will be a basis of comparison for future settings.
But could it not, Dr. Mar? Like, let's say you have someone who has additional bone mets, right? Or like, you know what I mean? I don't know. I would definitely get it. I think that's, and like you said, it's almost at this where we are inevitable, but it can change my thoughts, right? If someone has like what thought to be 3 and then upstage to 6 or 7 bone mets, that's a different patient, right? In some ways, depending on the location, of course, but I think it's definitely helpful. Yeah.
I think maybe what I meant to say was it probably won't change the therapy from a systemic standpoint.
Yes.
But
yeah.
from if you are considering radiation, which we'll discuss, it might. So
I think it definitely will. Yeah, and I'll show some interesting data about what happens when you ignore PET avid lesions actually on SBRT. So
very nice. So yeah, probably yes to PSMA PET in most patients. Okay, and then we're gonna get into the kind of bread and butter part of this case. How would you approach treatment in this scenario? And I listed out a menu of options here that you might consider for this low volume hormone sensitive prostate cancer patient. So choices here would be metastasis directed therapy, SABR, which is kind of what Dr. Seyedin is going to talk to us about a little bit. The role of radiation to the prostate primary tumor in this case, role of androgen deprivation therapy, and if you're doing it, are you going to do it in a continuous fashion like you would in a high volume space or intermittent fashion, and what kind of features about the disease would steer you in kind of one versus the other direction. Would you add a novel hormonal therapy agent in this case? So we have really good phase 3 data from the trials that I listed with 3 novel hormonal agents that says that they're active in this space. And then I didn't write surgery because that's investigational at this point. It's not standard of care, but is there a role for prostatectomy even in this space?
Dr. Mar,
So maybe, yeah.
Dr. Mar, can I add in? So what about the role of combination chemotherapy and hormonal therapy, utilizing the ARASENS trial with combining docetaxel and darolutamide in newly diagnosed hormone-sensitive metastatic prostate cancer, which, based on this patient's profile, they would fit. And, that would be something that I think would also be a treatment option as well. I was wondering if the panel can discuss that as well.
Sure, no, that's a wonderful question. So we have 2 trials that came out recently, ARASENS being one of them, that looked at triplet therapy for metastatic hormone-sensitive prostate cancer patients and led to 2 FDA approvals with ADT backbone, docetaxel, and then a novel hormonal agent. So typically for low volume disease, maybe not something that I would necessarily kind of consider this in. High volume, it's more of a default for me to think of triplet first and then find the reason not to use it. But my first thought is always triplet therapy for high volume. For low volume, I'm not sure that I would do that kind of as a standard, but maybe Dr. Twardowski can tell me his opinion.
Yeah, I agree. And I may have, if we get to, have enough time, some slides kind of trying to dig a little bit into that dichotomy perhaps between high volume, low volume. I mean, intensification of therapy. But no, I agree with Ashkan. It certainly would cross my mind. And one of the problems, I guess, with these triplet studies, that the limitations in interpretation, that they essentially use the backbone of docetaxel chemotherapy or chemohormonal therapy as a standard of care, and then the addition of second generation hormone agent was the experimental arm. So it's a triplet versus doublet, showing advantage of triplet, but it was an advantage based on addition of hormone agent. And the big question is, what is the docetaxel contributing in that kind of setting? Is it really necessary, since we have studies also looking at doublets, just doublets showing benefit? So that's the area where I think there's some debate. And I agree with Dr. Mar that I would tend to give the patient, I guess, benefit of the doubt, or maybe perhaps myself also, and go with triplet therapy in those patients with higher risk, higher volume disease. But this patient is kind of on the cusp of that, as we've discussed. So certainly I would discuss it with him, but maybe ultimately may settle for the doublet.
Yeah, I agree. This patient is a little bit complex in the sense that, like we discussed before, by the book, he fits the low volume definition. And we have had kind of older studies that looked at docetaxel in low volume patients that kind of did not pan out. But I agree that he does have high risk features to him, which we pointed out before. So I think it's a consideration, but as a blanket kind of approach, I probably wouldn't offer triplet to, every low volume patient that walks through the door. It's maybe more of an individualized type discussion.
Would you consider it in someone who has more of an aggressive presentation? I mean, this patient is presenting with some elements of, cord impingement, and that certainly is concerning. Obviously, I mean, we'd want to consider maybe, radiation in that setting as well, maybe even surgery, depending on, the neurological status.
Right. I think he did receive
which this
surgery.
patient had, but
Right.
I guess that would be the other thing as well.
Yeah, I think it's a consideration. Again, it's a younger patient who presented with a pretty significant kind of bad problem in the beginning. So in this particular case, I would at least have that discussion with the patient. But let's say if you took that away and made him, let's say 70, and let's say he didn't present with cord compression, he just had a painful bony met. I probably would not in that situation.
I think that's helpful. I think that provides some context to how, we can tease out some of these treatment options for these patients.
I would just maybe again point out to the PSMA PET, even though again, if you're a purist, you can always say that all these classifications are based on standard imaging, the high low volume. But once in a while we do see patients that you really on the PSMA PET you find the much more ominous extent of disease. Let's say if this patient did have a liver met that was pretty definitive, and I probably would have a hard time ignoring it and saying, well, it wasn't seen on the CT, and perhaps that would sway me to more towards triplet therapy based on PSMA, but even though you're a purist, maybe it's not quite, proven. But
yeah, I would say that the proportion of low volume patients has declined since more widespread use of PSMA PET. I would definitely say that.
Right.
Okay. So we're gonna move on because we only have 1 hour. And I'm gonna hand the mic to Dr. Seyedin, who'll talk about the role of radiation therapy to the prostate primary and metastatic sites. in low volume MCSPC.
Awesome. Thank you, Dr. Mar. I'll share my screen. And I assume everyone can see my screen?
Yes.
Yes.
Thank you. So yeah, the way I've broken this down is we're going to focus on the prostate first. And, I could give a whole talk, which is what I do for my residents, on just treating the prostate. But what I decided to do is just to pick probably the one trial that's probably influenced me the most, or one of the arms of said trial, was the Stampede trial. And so for most people here know that this is a study of about just over 2,000 men who either got lifelong ADT or lifelong ADT with prostate radiation. And I don't even put the doses, because I was once told that if you put doses of radiation, med-oncs don't like it. So I just say it's 4 weeks of daily radiation, or it was, weekly for 6 weeks. And that's how they did this study. And they did use the same definition as chartered. And I don't get too much into design here, but it was purely just the prostate. So it was actually done with what they call a 3D conventional technique of just treating the prostate with really big margins. And the primary endpoint was overall survival. Granted, they looked at freedom from failure, survival, and biochemical failure. And then, like mentioned, we classified these groups into either low or high by the charted definition. And you can see here, while there was no overall survival benefit to this cohort, you can see that the low metastatic burden did appreciate about a 8% difference in overall survival at 3 years. The interesting thing is, if you actually look at the median survival of the low metastatic cohort, it's something about 45 to 43 months versus 48 to 49. So you're probably getting about an overall median survival benefit of 4 months, which is still important, but just kind of to know, when you're discussing with patients, would they ask, well, how much is this going to really benefit, right? And you can see then, similarly in the low metastatic burden cohort, right, that these patients also had a failure to free survival as well as PFS benefit. I always like to show this because, actually was brought up about grade, and do these things kind of, make a difference, right? And when you look at the forest plot here, really, when they looked at it, it was really just the low burden patients that had the overall survival benefit that favors radiation therapy. It wasn't about weekly schedule versus getting it daily for 4 weeks. It was not their age or their tumor status. So that's just something I tell their residents. And again, I think someone had pointed out, potentially they roll docetaxel, and some of the patients in the Stampede did get docetaxel. So you can see that also did not impact the role of radiation here. I always like to point this out because patients ask, well, what's the toxicity of your treatment, right? And is it going to matter whether I do this weekly or daily? The answer, quite honestly, is no. I have on the left-hand side here the breakdown of toxicity by either weekly or daily schedule and by bladder and bowel toxicity. You can see really the rate of grade 3, grade 4 toxicity is similar in the bladder. It's about 5%. And then in grade 3, grade 4, and this is by RTOG, so not CTCA, which is what we use more commonly, but it's about 1%. And then compared to, on the right-hand side, when you look at rates of toxicity compared to a non-radiated arm, they're fairly similar, probably a little bit higher. You could see it's 1% versus none, but pretty negligible in the grand scheme of things of, late grade 3, grade 4 toxicity. Believe it or not, I keep liking this study because they come back to it and they reanalyze it. So a couple years later, they did actually publish an analysis of, because this is a question I think was really well brought up, was well, who's really low burden? It comes in a variety of flavors. How much do you benefit depending on, your disease presentation, right? And so this is kind of what they did in this study. It was published in 2021, where they looked at, by number of bone mets, what was your survival going to be benefit? And then for those who have non-regional lymph nodes, and that's a challenge for Rad Onc sometimes, because depends on what you define as non-regional, like common iliac in the butt and so forth. But and actually, there should be a dash, obviously, for visceral mets, because they did look at whether patients with visceral mets alone benefited. But what I want to get away with here is you can kind of see the overall survival graph. It's bone mets on the x-axis, and on the y-axis is the hazard ratio. So clearly, when you're crossing 1, that probably means the benefit's not really there. And in terms of number of bone mets, the answer for treating the primary, it was around 3, right, for overall survival. Now, if you're looking at failure-free survival, which is I would say easier metric, because you're just looking at PSA2 and maybe not as, I would say, meaningful. right, then the number goes up quite a bit, all the way to like 8 or 9 bone mets, right? But I tend to really focus more on the overall survival, and that's why I really like this breakdown by bone met, percentage. So my patients who only have 1 bone met are going to probably get the best benefit from prostate radiation therapy, and that's kind of how I counsel them. And after 3, the role of treating the primary, although granted, I think it's been touched upon here, maybe 4 or 5, right? You don't really know de novo versus metachronous, right? It's very different presentations. But with that being said, yeah, I would say for these de novo patients, I think treating the primary, it could be beneficial up to 3 bone mets. Let me move on. Perfect. The other thing that I really was curious about was non-regional lymph nodes, because it's not a common presentation. Obviously, usually patients with metastatic disease will present with some sort of bone met. But for your patients that have non-regional lymph node mets, I was very curious to see what the benefit would be. And you can see it on this top part of the graph, or the table, excuse me, that the hazard ratio was 0.6. It does cross 1, but I also just wonder, because it's such a rare presentation, you can see standard of care versus radiation, that they only had about, short of 200 patients, right? Otherwise, this is kind of what we would have expected. When they make the cutoff at 3, the statistical significance remains significant. At 3 years, the survival benefits around 10% for all comers versus greater than 4, right? And it doesn't matter, bone mets plus or minus non-regional lymphadenopathy, right? So I think that's something to think about when I'm counseling my patients. Keep going with this study. They actually published even later data, because I'm always curious about quality of life, obviously, with each dose and fractionation, because while the toxicities are similar, patients' convenience and schedules just depend on where they're coming from. And so here we have with later follow-up on late toxicity. I think the mean follow-up period was about 5 or 6 years in this publication. They still not appreciating any big differences between weekly and daily doses of radiation, right? So urinary toxicity, late grade 3-4 was around 2%. Same thing with the bowel as well. But what I love about this republication was this graph, and it made me really think, and I don't have a great explanation, but what I'm showing here is actually the graph to the left is an overall survival curve of comparing standard of care lifelong ADT versus the weekly radiation group for those who enrolled into that part of it. And then the one to the right is for those who got the daily 4 weeks of radiation. Now, I want to be clear here. This is all comers, so low and high metastatic burden. And yet, for some reason, in their overall survival curves for the entire group, the 55 gray actually separates and actually has a survival benefit. So now I started to scratch my head a little bit and think to myself, is 3 my number that I should be so strict about or not? And maybe I should be a little bit more flexible, right? Now, granted, in the low metastatic cohort, I don't show this data, but the weekly fractionation still has a survival benefit. But this was, again, looking at the entire cohort, which I thought was really interesting. So how has this kind of affected my practice, almost like in conclusion, right? So yes, by charted definition, I do offer primary prostate radiation, but really it's for those patients that have like 3 or less bone mets is where I think you get the biggest, I would say, is bang for your buck from treating the primary prostate. I go by patient preference, right? We have patients when I was practicing at UCI who live, 2 hours away, an hour away. They don't want to come in every day for 4 weeks. They rather just come in once a week for 6 weeks. And I have patients who are just really close by, or they just want to get it over with faster, right? And so, and then there's this kind of like gray zone of when you go beyond 3 or 5 bone mets, you're not 100% sure. Well, semi-extrapolating from that last graph, or maybe there is a benefit from a broader cohort with the 4-week course, then maybe consider it, right? And that's a very complex multi-D discussion, right? And I think it requires the ideal patient, right? In terms of like who you offer something that's outside of the lines of charted. I don't treat the nodes, for example. Some people ask me, do you treat the nodes for, because I get these patients with like lymph nodes in their chest and whatnot, and I don't go chasing them. I do sometimes, and I don't show this slide here, for patients who have common iliac lymphadenopathy, and that's it, so nothing above that, I will actually switch over to a more traditional, longer course of radiation. And there's just some data that suggests that perhaps has a similar outcome to those with N1 disease, right? And actually, it's funny, I just saw a guy like that today, and I always tell them the options, like I can treat your prostate alone, or I can include the nodes. One's more aggressive. This is a gray zone, and how aggressive do you want to be? And then they just kind of let me know. So Moving on to metastasis-directed therapy, known as SABR or SBRT, kind of very similarly. This is probably one of the first studies that really made the splash for being aggressive in prostate. You know, it's funny. I used to tell residents when I'd ask them, "Oh, how do you want to treat the Mets?" They go, "Oh, like we used to quote this study, SABR Comet," and I never liked when residents quote that, but you might have heard that in the literature because it was really what put SBRT for oligomets, but they had very few prostate patients. So I was very happy when this trial came out, even though it's much smaller in comparison. But it was essentially kind of a unique trial where they took 54 patients and randomized in 2-to-1 fashion to just SABR versus observation, just to be very clear, for those who have asymptomatic 1 to 3 Mets. A PSMA PET, when this started, was not required, but I'll show you some data for those who did get it and what it impacts. Actually, interesting, we brought that up earlier. And then, yeah, you've had to have your primary prostate already treated. So again, to the discussion before, this is not exactly our, upfront metastatic patient like the one we just discussed in the case, right? And then they were allowed to have received some prior ADT. But the endpoint here, little, I don't know, 6-month disease progression, as what I mentioned here below, by PSA or by radiographic failure, or a 25% increase. Clinical meaningfulness to me isn't as robust here, right? But I think it's just something they want to report pretty quickly after a short-term accrual. But what you can see here, obviously, as you might expect, for those who have low disease burden, here again by dividing by 3 or less bone mets, that the 6-month disease progression was much lower in the SABR arm, and the progression-free survival was not even observed. Granted, the median follow-up here was pretty short; it was less than 2 years. So I think I wouldn't think too much about it, but it's what you would expect. And then with the observation, within 6 months, they were probably on ADT, and they didn't appreciate any severe grade 3, grade 4 toxicity. I always say that because I talk to people and they're like, "Oh, does radiation deplete your bone marrow, or SBRT or SABR?" And I'm like, "No, this does not deplete your bone marrow." Now, pelvic radiation can. That's whole pelvic radiation. I always have to clarify that with some people. That's why I put that slide there, or that pivot. Now, this is the part I think is really probably my favorite part of this paper, actually, is there were some patients who actually had PSMA PETs at the time, or fluciclovine PET related at the time. And they actually looked at these patients, and there were some patients that had SABR to all their bone mets, and there were some of them that had PSMA PET, but not all their bone mets are SABR'd. And this is what I think is interesting. You can see here in the graph, on C being progression-free survival, and the graph on the right being, Mets-free survival, that not treating the PET-avid lesions actually did result in a lower PFS and a distant Met-free survival. So that's actually, something I thought was fascinating. It spoke volumes about, the meaning of treating these lesions, right, in the oligo or 3 or less setting. This is the last trial I'll mention. It's probably the one that I have my practice the most similar to, right? And it was a phase 2 that really mostly came out of MD Anderson, looking at 87 patients that were randomized. And actually, they did allow for, I'll put this, for castrate-resistant prostate cancer, but really for oligometastatic, similar definitions. They allowed up to 5 bone mets, but SABR plus ADT, and they did allow for NHT as well, versus ADT alone. And then they would take a treatment break at 6 months. And this is important because I think one of the questions that Dr. Mar had in her slide was about treatment breaks, right? And some patients really like the opportunity to try to take a treatment break after a certain time. Granted, when that occurs, that's kind of a nuance, but they took theirs after around 6 months, plus or minus a couple of months. And they were looking at PFS, similar to, what they used in Oriole to define that. But what you can see here, median duration of ADT was similar in both arms, and the progression-free survival was higher in the SABR arm, right? And it's not really exactly a surprise, but what I really liked about this was that they're eugonadal, meaning their testosterone being above 150, median progression-free survival was much longer, and you can see that in these arms. And so sometimes when I see this, and patients that just absolutely abhor ADT, but I just don't think they're good candidates for SABR alone. And actually, I will comment on that. Actually, I have one more slide after this, or one more study, but it's just an abstract. I bring this up with them, and I talk with Dr. Mar, Dr. Razaz at UCI, and say, "Hey, what do we think here? Like, how long would you do it for? And is it reasonable to give them a break and see how they respond?" Just here is really no differences in toxicity or quality of life, and you can kind of see you know, when you break down by the number of meds that they looked at, 1 to 5, maybe those with 1 to 2 might have the biggest benefit, right? And I forgot to mention here that I thought I had in the slide, but maybe I might have missed it, that the numbers of those who received NHT were similar in both arms. So that just to not give it a, oh yeah, and I think, I don't know, actually, yeah, even the use of second generation anti-androgen, right? It did not impact your hazard ratio significantly or interact with radiation. This is actually a study I put in because, you know, the studies I just listed have been out for a couple of years, and I wanted to add some actual newer data. And this is a question I get a lot is, you know, okay, well, how many times can you keep sabering, right? Like, you know, you do it once and they fail, right? And then should you do it again? And I never know the answer to this question. It's one I debate so much. And this is actually data that came out of where I am now. And it's funny, when I didn't even know this data existed until one of my fellow med oncs mentioned it to me. He actually is the one who wrote the abstract and the paper for it. And what they did was really interesting. They looked at patients who had gotten 2 or more courses of SABR, but they had to have had PETs at all time points, so SABR 1, 2, and 3, just to get a pure assessment, right? And so they looked at the predictors of progression-free survival, and this is just SABR alone. I want to be very clear. There was no ADT here. And a multivariate analysis, they really appreciated that your PSA decline at the first round of SABR, your PSA doubling time at that time of the second SABR were quite predictive of how you were going to do. And so when they started with 34 patients, I also, you know, wrote down how many of them were ADT free, right, at each round. So after SABR 1, only 23 were free. After SABR 2, it drops to 14. So you can see, right, like there's going to be less and less people that can do this, right? And that's how I counsel patients. I'm like, you know, your first shot is your best shot to try to get off ADT. And the second one, depending on the biology of what you have, it's a little more different. And so kind of putting it, oh, actually, I'll mention this as well. So I broke it down. I went through and broke down, you know, the percentage of patients that had castrate-resistant disease at the time of presentation, their PSA 50, how many of them achieve a PSA 50 decline, their progression-free survival, and then the systemic therapy change-free survival, as you might call it, right? Changing treatments. Clearly, again, that first round is probably your best shot. You can see, you know, they have pretty durable, you know, systemic therapy change-free survival of like almost, you know, just over 3 years, pardon me, right? And yet it drops quite a bit. So this is just helpful for me when I have a patient on round number 2. I kind of use these factors, their decline, their rise of number of bone mets, are they castrate resistant, and things like this to really help them understand, because sometimes they think, like, I have a guy just saw, he wants his 4th round of SBRT. He really doesn't like ADT. Not my ideal case scenario. And I'd be pretty upfront. I'd say, I don't think it's going to last you for more than like 6 months to a year. And there's a risk of re-radiation. So just how it impacts my practice. So kind of just putting this together, right? So someone who's newly diagnosed with oligometastatic, you know, castrate-sensitive prostate cancer, I treat the primary, and then usually I try to radiate the met, obviously. And then I feel like our practice has been to do 2 years of ADT. If they can't tolerate it, that's great. And then kind of reassess and where they're at after those 2 years. If their PSA is undetectable after a year or 2 and they're really begging, right? It's, again, a discussion you have. And then whether you discontinue the ADT or not, right? Some patients just tolerate it better than others, and you guys know that better than I do. And then for those who have had the primary treated, again, you know, examine the number of sites, your doubling time, your PSA dead time. If there's no prior radiation, then sure, I'm usually pretty open to treating the meds and then plus or minus 6 months of ADT, like extended, right? Or even with the doublet, right? Depending on the patient's biology. But if they've had prior SABR and they want to do it again, or they are castrate resistant, sometimes I say, hey, let's just switch up the therapy, because I got a feeling the ADT is helping me get better control of these meds anyway, right? So just, you know, if you try a different line of therapy, you actually might notice an improvement in your control. And I think that's my last slide. So I really am done. I hope I didn't go over my time, so I apologize. But thanks for the opportunity. I'll take any questions, or we can save them to the end.
That was really wonderful. Anyone, so we're a little bit kind of pressed for time, but any comments, Dr. Twardowski, Dr. Lashkari, audience, any comments on this or questions?
No, it's a great review. I've learned a lot from that. It sounds very reasonable approach. I would definitely subscribe to that kind of algorithm that you outlined.
Appreciate it. Thank you so much.
Yeah, that was a wonderful talk. Okay, so moving on. I'm gonna give you a very brief kind of two cases. The reason why there are two is just so you can contrast these two patients. So the first case is a 50-year-old man with no past medical history who presented to the emergency room with severe hip pain after a fall. He has a CT scan of his abdomen and pelvis, which reveals an enlarged prostate, pelvic and retroperitoneal adenopathy, innumerable bony lesions, and an acute right femur neck fracture. PSA was 7. Patient was taken to the OR for surgical repair, and pathology shows metastatic adenocarcinoma of prostate origin, and his ECOG prior to the fall was 0. And then to contrast that, a second case is a 79-year-old man, past medical history of hypertension, diabetes, CAD, status post 2 stents in the past, and a right inguinal hernia, who was undergoing pre-op clearance for hernia repair. Chest x-ray showed bilateral pulmonary nodules. CT chest showed multiple bilateral nodules. CT abdomen pelvis showed an enlarged prostate and 10 bony metastases in his pelvic bones and spine. PSA was 58.3. He undergoes a biopsy of the largest pulmonary nodule that shows metastatic prostate adenocarcinoma, and his ECOG is 2. So I know that was a lot, but how would you classify these patients' prostate cancer?
I
Yes,
mean,
I think,
patient number 2.
Oh, go ahead, Stephen.
No, I was just gonna say patient number 2, I feel like has all the wrong things stacked against him. Age, comorbidities, the disease burden, visceral meds, his performance status. So that I feel like that's the easy one that even me as the rad onc would know. There's no real role for radiation unless he's in pain from his meds or has a symptomatic met. But I would say very high burden, very poor prognostically. That's kind of my thought.
Yes, so that's why I gave you these two cases, which are very different from each other and also are very different from our first case. So this is high volume metastatic prostate cancer, right? Both de novo cases, high volume. All right. So just very briefly to go through that. So for someone with high volume de novo metastatic castrate sensitive prostate cancer, we basically use either doublet therapy or triplet therapy. So we kind of alluded to that in the beginning. So doublet therapy is basically an ADT backbone plus either a novel hormonal therapy agent or docetaxel. And I listed the trials supporting the use of each of these. So these are all large randomized phase 3 trials. So category 1 evidence, best evidence we have. And then more recently, we have 2 trials, like we mentioned before, ARASENS and PEACE-1 with triplet therapy. These combinations of triplets are now FDA approved. So we have, again, ADT backbone plus docetaxel plus an NHT agent, novel hormonal therapy agent. So a couple of kind of questions, food for thought here. What factors influence your decisions about first-line therapy for MCSPC, meaning doublet versus triplet? And then combining that with what therapy would you offer to patient 1 versus patient 2? So maybe briefly we can comment on this. Dr. Twardowski, maybe?
Sure, happy to do that. Let me see if I can share a couple of my slides. And I don't know if you can see my slides or not yet.
Not yet. So,
Yeah.
so I guess.
Oh, wait, I see him.
Yeah, we can see him. We can see him.
You can see.
Oh,
Oh, okay. So
here we go.
okay, so if you guys can see it, that's good. But I guess I don't hear consistent confirmation.
We can see them.
Okay, great. So briefly, because I know we are a little bit short on time, but as Nataliya mentioned, this treatment intensification concept for metastatic hormone-sensitive prostate cancer kind of started, I guess, almost 10 years ago now, with addition of docetaxel as an example of expanding beyond standard ADT. Here you see kind of overall survival benefit of adding 6 cycles of docetaxel. And this is where this concept of kind of division between high volume and low volume disease was presented, where there was clearly benefit in this high volume patients for addition of docetaxel in the panel B. In the low volume disease, the difference wasn't statistically significant. So that's kind of when the treatment intensification, at least with chemotherapy, was perhaps more limited to that subgroup of patients. Now, very soon after chemotherapy, as Nataliya mentioned, there are multiple clinical trials indicating very consistent benefit of adding, second generation hormone agent to backbone of ADT, and with abiraterone, apalutamide, enzalutamide, and that was very consistent, with overall survival benefit in pretty much all of these studies. And then, as medical oncologists, we are obviously perhaps sometimes not super innovative, and we think, well, if chemo had benefit, if second generation hormone agent had benefit, why don't we combine all of this? And that's kind of where the triplet therapy concept originated. But I think what we've been alluding to, the challenge was that when these studies originated, the ADT plus docetaxel was considered standard of care. So the comparator arm was based on docetaxel with addition of second generation hormone agent. Well, de facto at that time, when these trials were ongoing, the doublet of hormonal therapy became more or less extensively used. So that created a little bit of a challenge in interpretation of the results. But nevertheless, the triplet therapy studies included this addition of darolutamide to ADT plus docetaxel, and another dose called Arasense, and addition of abiraterone to ADT and docetaxel piece 1. And here, in general, there was pretty impressive, overall survival advantage in those studies for the whole population. However, when you again divided them into low volume and high volume disease, the data was really robust for high volume disease and not so much on low volume disease in terms of benefit of adding second generation hormone agent to docetaxel ADT backbone. And I think based on that, and some of the difficulty again in interpreting these studies in the era where the doublet therapy became much more dominant as a standard of care, I think a lot of us would offer this very intensified treatment with 3 drugs to patients who have high volume or high risk disease, who have very good performance status, no real significant comorbidities, essentially like patient 1. But 50-year-old gentleman, innumerous bone mets, very, very low PSA, frankly, which in this kind of setting is always a little bit of an ominous sign. But it is a little bit of a stretch because, again, we don't know, frankly, there's no study, to my knowledge, or large randomized study that would look at backbone of ADT plus second generation hormone agent plus minus docetaxel. So that's kind of the study that would be interesting to have to see what really docetaxel in the modern era, what is it adding to doublet therapy? We just don't know that. So, we kind of have to make some, judgments. And I think it's reasonable to offer, the most intense, safely administered triplet therapy to appropriate patients with the highest risk, hoping that indeed, that docetaxel makes a difference. And clearly we know that adding second generation hormone agent is consistently been shown to be beneficial. On the other hand, in the second patient, as I think we've already commented on, he's much more of a difficult patient in terms of overall health kind of background, elderly gentleman with comorbidities, with coronary disease, performance status that is ECOG 2. So, somebody who is, just barely kind of able to take care of himself or is able to take care of himself, but not super robust. I think to me, giving him chemotherapy in this setting would be a little bit of a stretch and perhaps associated with, at least for me, excessive risk of adverse events from docetaxel therapy. And I would really focus on doublet therapy with a gentleman. And the choice of agents is really very difficult to make in any kind of logical way. But perhaps in somebody who has cardiovascular disease, maybe abiraterone would be less desirable because of fluid retention, some maybe more cardiovascular adverse events. So I would probably go with something like apalutamide or enzalutamide. But all of these agents really are very effective in general. So that's kind of abbreviated, I think, summary what in the allotted time that I had, I would make, but I'm happy to expand more if Nataliya wants me to. I think you are on mute, Dr. Mar.
Oh, sorry about that. So that was such a wonderful summary. I love this slide that kind of gives you a one slide kind of look at all of these of these large trials. So let's maybe go back to our slides here, and maybe Dr. Twardowski can help us answer those questions. So would you kind of already have, but would you offer then a triplet to the first patient and a doublet to the second patient?
I think so, yeah, because the first patient, the way he presented, I mean, he really has all of the characteristics that would make me think about it. 50-year-old gentleman, innumerable bone mets, fracture, low PSA, which actually in this setting I find as a negative kind of prognostic indicator, indicating poorly differentiated cancer. So I think I would offer him the most intense systemic therapy that we know has been shown in randomized studies to be effective, and that would be, I think, my pretty strong recommendation. But as I mentioned before, on the second patient, has some more risks associated with exposure to triplet therapy. I think in terms of adverse events, infections, fluid retention that you can get with docetaxel. So I think margin for error in the kind of patient like that is less. And even though I do acknowledge that he has a high risk, high volume disease as well, with visceral metastasis, because as I mentioned before, we don't know exactly what docetaxel in the triplet therapy is contributing. As I'm willing to give the first patient benefit of the doubt and include it, I think in second patients, I would be more inclined to stick with the doublet therapy, which has less of these acute risks of chemotherapeutic exposure. But I acknowledge that some physicians probably would be more willing to take that risk and at least discuss it with the patient.
Very nice, and I agree with that approach. And just the very last question. So there have been several data sets published recently that show that kind of real life treatment of this patient population, high volume MCSPC, doesn't really mirror these guidelines, doesn't really kind of give these treatments to this patient population, and what you see more is just ADT or ADT plus bicalutamide given, and actually the minority of patients get treatment according to guidelines. So in your practice, is there a scenario where you would give just single agent, let's say ADT or ADT bicalutamide?
You know, it's really hopefully very rare. I think sometimes I do have patients that really decline the second generation hormone agent for various reasons, or you know, might have been started already and have done well for a very long time on single agent and with undetectable PSA. So there are some exceptions, but I agree with you. It seems like the uptake of the doublet therapy, at least doublet therapy in metastatic hormone sensitive cancer, maybe is a little bit subpar, you know, based on the very robust data that we have. So I think there are really, you know, some cases that I mentioned that patient driven, you know, sometimes, hopefully not often, and still financially driven, where the access to the medication may be really prohibitively expensive. That could be a factor still occasionally. But for the most part, I would really strongly recommend, you know, in metastatic setting to use, you know, this doublet therapy with a modern second generation hormone agent.
Can I ask you, this is Ashkan Lashkar, can I ask you a quick question regarding the role of intermittent versus continuous ADT therapy? Can you comment on you know, are there some patients that you recommend one form of ADT, treatment over the other?
If I can get great help from Dr. Seyedin, like he pointed out, with, you know, more isolated metastatic disease that kind of is fully irradiated, you know, I think he was mentioning those treatment interruptions or breaks that essentially perhaps is in fact like intermittent hormone therapy. I think that's perhaps a reasonable approach. On the other hand, you know, if you're using available data in terms of more extensive metastatic disease that it's not treated with metastasis-directed therapy, you know, there was a SWOG study that I remember participating in that looked at this question specifically, intermittent versus continuous therapy, and there was, you know, small but statistically significant survival advantage to continuous therapy. So I would probably prefer that, but then again, it could be patient driven. If the patients really are struggling with side effects of ADT, you know, I certainly would be willing to consider that. But it wouldn't be my recommendation, kind of proactive recommendation, to say, hey, patients who have, you know, extensive metastatic disease, my default would be, you know, continuous therapy.
Yeah, and I agree
appreciate that.
with that as well. So for me, the intermittent versus continuous comes in more in the setting of biochemical recurrence, more so than metastatic disease. And I always favor intermittent in that space. For metastatic disease, the default is continuous, but there are some exceptions, mostly when the patient asks for a break because of toxicity. And there are, however, ongoing trials looking at this. So in patients with MCSPC who are good responders to treatment, who had a PSA drop to 2 or less, we have a couple of protocols like this at my institution currently ongoing. What's the role of continuing ADT versus having a break, essentially? So that question kind of remains to be answered, but I do it in selected cases sometimes.
Yeah, me too.
Okay, well,
Thank you.
Just we're kind of a little bit over time, but I wanted to ask the audience to see if there were any comments or questions, or maybe from our panel? Any last comments or thoughts?
Dr. Mar, thank you so much for moderating this wonderful session. And to our two guest panelists, Dr. Twardowski and Dr. Seyedin, thank you so much for joining us. This was a really lively discussion, and I think, you know, just touching on a few of these brief cases just highlights the many challenges that go into treating these patients. Thank you, everyone, for participating this evening, and I think we can call it a night. Thank you.
Awesome. Thank you so much. Thank you, Dr.
Thank
Mar,
you.
for organizing.
Thank you
Yes,
for
thank you,
inviting
Dr. Mar,
us.
for
Thank you so much.
Thank
Good
you.
night,
Have a
everyone.
good one.